Hello everyone, and welcome to my YouTube channel, Studyholic Doctor. My name is 정식. I recently had the privilege of speaking at the World Organization of Family Doctors, Asia Pacific Region Conference 2025 in Busan. Today, I want to share the core message from my presentation with you, discussing the practical approaches to intravenous fluid management in hospitalized patients. Intravenous fluid therapy is a cornerstone of patient management in hospitals, but it's also an area where we need to be very careful. Let's dive into some key concepts and case example. I shared by considering a case. This patient is a 78-year-old female who is bedridden due to a cerebral infarction that occurred 2 years ago. She was admitted to the hospital 4 months prior. Yesterday, her aspiration worsened and her food intake decreased to less than a quarter of her usual amount. Infections like urinary tract infection and pneumonia were ruled out. Her vital signs were BP 101, heart rate 88, respiratory rate 16, and body temperature 37.1 Celsius. Her height is 155 centimeter and weight was 42 kilogram. Looking at her blood test results, sodium 132 milliequivalent per liter, creatinine 1.0 milligram per deciliter, and albumin 2.9 gram per deciliter. What fluid would you prescribe? The options include TPM fluid 2 liter, 5% dextrose water 2 liter, 5% dextrose NK2 fluid 2 liter, 5% dextrose saline fluid 2 liter, and 5% Hartmann dextrose 1 liter. After intravenous fluid administration, her daughter expressed concern about the patient's swollen feet. How would you explain this? This case highlights the challenge of fluid management in the elderly. It is crucial to understand that elderly individuals have a different physiology compared to younger adults, which affects their fluid and electrolyte balance. Key changes include decreased total water, decreased glomerular filtration rate, and decreased urine concentrating ability. They also show increased antidiuretic hormone and increased atrial natriuretic peptide, but decreased aldosterone. Elderly individuals also show more fluid retention compared to younger adults, which is associated with diastolic dysfunction. A significant concern in hospitalized patients, especially the elderly, is hospital-acquired hyponatremia. This occurs at approximately 15 to 30% of hospitalized patients. Most are at risk due to ABP excess. The most serious complication is hyponatremic encephalopathy, which is a medical emergency that can lead to fatal or irreversible brain damage. Chronic hyponatremia can cause subtle neurological impairment, gait disturbance, falls, and fractures in the elderly. It is also a risk factor for hospital mortality, increased costs, length of stay, and readmission rates. Because of the risk of hyponatremia, hypotonic fluids such as 5% dextrose water and 5% dextrose NK2 fluid should be avoided in case of hyponatremia. For normal maintenance, the requirements are usually water 25 to 30 ml per kg per day, sodium potassium chloride up to 1 millimole per kg per day, glucose 50 to 100 gram per day. However, we should consider prescribing less fluid, for example, 20 to 25 ml per kg per day, in patients who are older or frail, have renal impairments or cardiac failure, who are malnourished and at risk of refeeding syndrome. The patient in the case weighed 42 kg and had hyponatremia. What fluid would you prescribe? The most appropriate fluid for these patients is 1 liter of 5% Hartmann dextrose fluid. Also, 5% dextrose saline fluid is a good choice if you are administering 1 liter. Hypotonic fluids such as 5% dextrose water, 5% dextrose NK2 fluid should be avoided in case of hyponatremia. Edema is an abnormal finding. Find the cause, and if it is fluid overload, it should be reduced. This brings us a crucial principle in fluid therapy: less is more. Initial excessive fluid therapy in sepsis is associated with increased mortality. Excessive fluid is also harmful in acute pancreatitis. Consider 3 liters on the first day and less than 2 liters from the next day in acute pancreatitis. Flu is a drug. Unnecessary, excessive fluid therapy is harmful. Side effects of fluid overload should be considered and avoided. Fluid should be administered according to the phase of fluid therapy, such as F phase and flow phase. In general, consider balanced crystalloid first, such as Hartmann solution and plasmalyze. Another important principle in fluid therapy is the earlier the better. In septic shock, the target for blood pressure control is mean arterial pressure higher than 65 mmHg. Norepinephrine is the first-line treatment in septic shock. Use norepinephrine early in septic shock. I'm diving into a critical topic in intensive care: fluid therapy in septic critically ill patients. Fluid resuscitation is a cornerstone for managing sepsis, but it's also a complex area where timing, volume, and the types of fluid truly matter. Based on our source material, JAMA review article, let's break down the key principles. I will cover 4 main areas: when to start fluids, initiation, when to stop them, discontinuation, what fluids to choose, fluid choice, and finally, how to remove excessive fluid remover. Let's start with initiation. When do we start giving fluids to septic patients? This JAMA review article tells us to start fluids in sepsis-induced hypoperfusion. What does sepsis-induced hypoperfusion mean? It means the body isn't getting enough blood flow due to sepsis. This can show up in various ways, such as altered mental status, hypotension, or oliguria. Moving on to discontinuation. Just as it is important to know when to start, it is vital to know when to stop. We should stop fluids when perfusion improves, there is no further response, or signs of fluid overload appear. Fluid is a drug, and like any drug, unnecessary or excessive therapy is harmful. Next, let's discuss fluid choice. This is a key area where practice has evolved. This JAMA review article strongly recommends we prefer balanced crystalloid, such as linger lactate or plasma light, over normal saline. We should also avoid hydroxyethyl starches. Finally, let's talk about fluid removal. After initial resuscitation and when the patient stabilizes, maybe vessels are decreasing and the perfusion is adequate, we need to consider de-escalation, post-resuscitation after stabilization. This often involves removing excess fluid accumulated during the early phase. How do we remove fluid? The first step is typically to use diuretics. If volume overload is unresponsive to diuretics, consider renal replacement therapy. Let's start with a case patient. He is a 70-year-old male. He seems somewhat lethargic and could not eat breakfast. He is bedridden due to a cerebral infarction a year ago and was admitted to a hospital 2 months ago after being treated for aspiration pneumonia. He wears a diaper but hasn't urinated since yesterday evening. Chest examination revealed tachycardia, tachypnea, LAR, and cracker on right upper lung field. Repeat vital signs showed BP 101, heart rate 105, respiratory rate 22, body temperature 37.23 Celsius. What should we do for this patient? This case highlights important characteristics of sepsis in the elderly. About 40 to 50% of elderly septic patients may not have a fever response. Non-specific symptoms like altered consciousness, lethargy, loss of appetite, and altered vital signs are common. Above all, it is important to have a high index of suspicion from the beginning. To help with suspicion, even outside the ICU, we can use the quick SOFA tool. It assesses 3 criteria in patients suspected of infection: altered mental status, SBP less than 100, respiratory rate 22 breaths per minute or more. If 2 or more of these items are met, it suggests poor prognosis. Looking back at the case patient, his repeated vital signs showed respiratory rate 22, heart rate 105, body temperature 37. He was also lethargic and couldn't open his eyes well, suggesting altered mental status. His respiratory rate was 22, meeting a second criteria. Initial steps include labs and administering Hartmann's solution or normal saline 300 ml, intravenous rapidly infusion, and empirical antibiotics such as piperacillin and tazobactam under suspicion of sepsis due to pneumonia. Later, he developed fever. Lab results showed leukocytosis and increased CRP, and his SpO2 saturation dropped to 88%. His BP dropped to 70. The case patient was diagnosed with sepsis and septic shock. Let's take a look at the history and the rationale behind evidence-based treatment for sepsis and septic shock. Historically, early goal-directed therapy was influential. The original 2001 study showed improved outcomes with fluid bolus therapy, minimum 30 ml per kg of crystalloid in severe sepsis and septic shock. However, subsequent randomized controlled trials showed no effect of EGTD early goal-directed therapy compared to usual care. Differences in administered fluid volume and vasopressor use were noted between studies. Differences in fluid challenge volume was also noted between studies. Importantly, these later studies highlighted a critical finding. Initial excessive fluid therapy was associated with increased mortality. Higher fluid volume in control group of EGDT studies were linked to a higher 90-day mortality. In limited setting in Africa, fluid bolus therapy significantly increased mortality in critically ill children with severe perfusion impairment. Higher fluid volume in the control group of EGTT ICT studies were associated with higher mortality. A meta-analysis of individual patient data shows EGDT had no prognosis improvement effect and higher hospitalization costs. In a study of Zambian adults with sepsis and hypotension, initial excessive fluid therapy was associated with increased mortality. In this study, relatively large amount of fluid were administered, with 4 liters of 24-hour fluid in the early resuscitation group, protocol group and 3 liters in the usual care group. Observational and retrospective studies have shown that rapid antibiotic administration were associated with lower mortality. However, fluid bolus therapy was unrelated to mortality. Clover trial compared the restrictive fluid strategy, vasopressor primarily strategy, with a liberal strategy in sepsis-induced hypertension. The liberal group received significantly more fluid in the first 24 hours, 3,400 milliliter versus 1,267 milliliter. But there was no significant difference in death before discharge home by day 90. The Clover trial showed that a restrictive fluid strategy may be a good option in the treatment of sepsis-induced hypotension. The BASICS trial compared the slower but faster fluid challenge rates and found no differences in 90-day mortality. The BASICS trial showed that slower fluid challenge therapy may be a good option in ICU patients requiring fluid challenges. So, how we know when fluids will help? I assess fluid responsiveness. This is the heart's ability to increase the stroke volume in response to fluid administration. It indicates whether giving fluid will improve cardiac output. The Frank-Starling curve illustrates this. Stroke volume increased with preload up to a point, but beyond that, further fluid doesn't help and may harm. Passive leg raising is one method to predict fluid responsiveness. This evidence reinforces a crucial concept. Fluid is a drug. Unnecessary, excessive fluid therapy is harmful. When capillary endothelial barrier function is impaired due to a septic shock, capillary leak occurs. In this state, excessive fluid therapy, especially fluid bolus, leads to extravascular movement of water, electrolytes, and protein. This can result in adverse effects such as pulmonary edema, renal interstitial edema, and intra-abdominal hypertension, potentially leading to decreased renal function. These are the adverse effects of fluid overload. Adverse effects of fluid overload can manifest throughout the body. Excessive fluid is also harmful in acute pancreatitis. So, consider 3 liters on the first day and less than 2 liters from the next day. Beyond the volume, the choice of fluid also important. Let's compare common crystalloids. Isotonic saline. It contains high sodium and chloride. Lactate Ringer's solution and Hartmann solution contains potassium and calcium ion similar to plasma, and lactate as a vapor. It is a balanced crystalloid solution. Plasma light is another balanced crystalloid solution. Normal saline is associated with increased risk of renal dysfunction, hypochloremic metabolic acidosis, and death. This is particularly relevant in the case with existing metabolic acidosis and hypochloremia, where a balanced salt solution like Ringer's lactate may be necessary. In septic shock patients, in-hospital mortality was higher in the group that receives only normal saline as initial resuscitation fluid. A study of non-ICU adult hospitalized patients showed that balanced crystalloid had a lower incidence of major adverse kidney events than normal saline. A randomized prospective study of ICU hospitalized patients showed that balanced crystalloid group had lower kidney injury and mortality than the normal saline group. The SMART trial in the ICU patient showed a lower composite primary outcomes with balanced crystalloid, and the trend towards lower in-hospital deaths, especially in patients with sepsis. Balanced crystalloid have also shown benefits like faster DKA resolution in specific patient group like adults with diabetic ketoacidosis. The BASICS trial is a study comparing balanced crystalloid to saline as fluid bolus therapy in ICU patients. Both groups received a relatively small bolus of fluid on the first day after enrollment, approximately 1.5 liter. The 90-day mortality was 26.4% in the balanced crystalloid group and 27.2% in the saline group. However, saline was better in patients with traumatic brain injury. Saline may be preferred in certain clinical situations, such as head trauma or metabolic alkalosis. Balanced crystalloids are preferred for dehydration, diarrhea, metabolic acidosis, and diabetic ketoacidosis. Albumin may be considered in hepatorenal syndrome with hypoalbuminemia. Another crucial aspect in septic shock is the use of vasopressors. Early norepinephrine was significantly associated with increased shock control in adults with septic shock. The traditional approach is to first administer a lot of fluids, including a bolus fluid of about 2 liters, and then start norepinephrine if the BP doesn't improve. Therefore, the traditional approach often leads to a positive fluid balance and complications such as pulmonary edema. However, rational fluid management is to start norepinephrine early if blood pressure doesn't improve after administering 200 or 300 milliliter bolus fluid, and to evaluate the fluid responsiveness with a passive laying method to determine appropriate fluid therapy. Let's apply this to case patient. After his vital signs worsened and sepsis and septic shock was suspected, the plan was: first, administer Hartmann solution of normal saline 300 intravenous infusion fluid bolus and passive leg raising. Target mean arterial pressure was higher than 65. If mean arterial pressure is lower than 65, another additional second Hartmann solution of normal saline 300 intravenous infusion plus start norepinephrine early. This approach aligns with starting fluids when hyperperfusion is present, using crystalloid, assessing response, and initiating norepinephrine early if the BP target isn't met. Monitoring fluid input and output is important. Case patients' IO record showed a positive fluid balance in the early phase. This is often seen in the F phase of sepsis, a distributive shock state. However, despite this positive balance, he did not develop pulmonary edema, intra-abdominal hypertension, or decreased renal perfusion due to fluid overload. As he improved, entering the flow phase around day 3, his fluid balance shifted to negative as his inflammatory stage improved. This illustrates that while positive balance can occur early, careful monitoring is needed to avoid complications, and a shift to negative balance is desirable as the patient recovers. To summarize the key takeaways from the research, initial excessive fluid therapy in sepsis is associated with increased mortality. Excessive fluids is also harmful in conditions like acute pancreatitis. Fluid as a drug, unnecessary excessive fluid therapy is harmful. Side effects of fluid overload should be considered and avoided. Fluid should be administered according to the phase of fluid therapy, such as F phase and flow phase. Prefer balanced crystalloids over normal saline in most sepsis cases. Use norepinephrine early in septic shock if needed to reach BP targets. Monitor fluid balance and assess fluid responsiveness. edema is an abnormal finding. Find the cause, and if it is fluid overload, it should be reduced. Thank you.